I was saying a very warm welcome to all of you joining us to this journal club by the International Academy for Clinical Hematology. It's 15 minutes past the hour, and I really do apologize for the delay. But actually, one of our panelists is stuck in a train, and hopefully, he will be able to join us in a couple of minutes. I'm Mohamed Moti from the Saint-Antoine Hospital and Sorbonne University in Paris, in France. And it is my great pleasure and honor to moderate this ICH journal club, which is a very special one today, uh, dedicated actually to the so-called best practices in hematology in general. And actually, we will use this very recent paper published in Current Oncology about the impact of best practices program in patients with relapsed refractory multiple myeloma receiving Selinexor, which is an XPO1 inhibitor. And it's a very nice paper and showing how by just modifying the way we administer, we give drugs, the schedules, the dosage, the duration of a given cycle, we can definitely improve the outcome. And our discussion actually will go beyond selinexor because it is absolutely relevant to any drug we use in multiple myeloma, and I believe beyond multiple myeloma. So you can see the abstract of this paper, and it's relatively straightforward. This is a team in Florida, I think, who was using selinexor for relapse refractory multiple myeloma. We know very well that the drug is approved in this indication. And actually, at some point, they have modified the dosage they administer, and they have just compared actually before and after the introduction of these best practices. And what you can see interestingly, actually, and you know that for every drug, we do have like an approved dosage or a recommended dosage, but for a given patient, you have to personalize the dosage. And the best example is what we usually do, for instance, with dexamethasone in the elderly, or with lenalidomide, or even actually with bortezomib, which is approved twice weekly, but most of us will use it once weekly. We don't use it IV, we use it subcute, while originally it was designed IV. And what's really interesting here is that by just small, very gentle, subtle changes, you can appreciate actually, you can significantly decrease the rate of discontinuation of the drug, going from 45 to 12%. Actually, you will reduce the incidence of adverse event. Uh, Actually, it will also improve the patient adherence to treatment. And if you decrease the incidence of side effects, adverse events, if you are able to allow patient to remain on treatment for longer duration, actually you will end up with a better outcome. And this is exactly the conclusion of the paper, where they definitely recommend, and I think this is really a very nice experience that the authors shared with us, that by just doing the right adjustment based on the clinical judgment for a given patient group. Actually, this is the spirit of what we would call personalized medicine. So, and this is really relevant to everything we do in multiple myeloma. I'm sure you've seen this slide hundreds of times, but for every drug that we use in multiple myeloma, actually, we do have to take into account whatever is the approved dosage and schedule, and how does this fit for a given patient in my practice. So it's a very special journal club, and actually it's even more relevant when it comes to managing elderly patients, because this is where we know very well that it's not only about age. We do have the modifications linked to aging, and it's a very hard to capture. We do have the comorbidities. Usually we know how to get them, the heart, the liver, the kidney. The polymedications are more complicated to navigate through. Autonomy of patient, social and family environment can play a role in the way a patient will handle and or accept to receive a given therapy. Cognitive status sometimes is neglected because it's not always obvious. And we know, for instance, there are statistics in different countries that above certain age, you have 10 to 15% of some cognitive problems, which actually are not diagnosed. Depression is also an important issue, and of course, nutritional status. So in order to discuss all of these issues, I have two guests. Dr. Elias May from Germany, who is already here, and he is a very active ICH contributor. And thank you, Elias, for being here. And the other panelist is actually Professor Thierry Facon from the University Hospital of Lille, who is stuck in the train, and hopefully he'll be able to join us in a couple of minutes. But let's start the discussion, Elias, at this stage. And at this stage, we'll start with the paper that I have summarized, and your thoughts based on your experience, because you have a quite significant experience with the use of this drug. What were your thoughts, and how do you believe that implementing some best practices would help to improve the outcome of the patient? And of course, this is a live interactive webinar, guys. So please don't hesitate to post your questions or comments, and I'll share them with the panelists.
Yeah, thank you for the invitation, Mohammed. It's a great pleasure to be here again. And yeah, I fully agree with you that I think that personalized medicine today does not just mean that we target specific lesions or whatever, but that we also tailor the treatment and fit the treatment to the patient that is sitting in front of us. And those reductions or those modifications, any sort of, are key to this. With regards to the paper, I quite agree with you, and I would say one important lesson that cannot just be learned from this paper, but also from other papers, for example, on the immunomodulatory drugs, taught us that it's not always needed and not always best to start with the highest dose possible or the highest recommended dose. And this is not just true for Selinexor, where I think 60 or 80 milligram is a good starting dose if a patient has not, let's say, a symptomatic, highly dynamic relapse. But it's also true for other drugs, like, for example, pomalidomide or lenalidomide. For example, with pomalidomide, I often start with 2 or 3 milligrams if that's possible, because if I do it the other way around, I often see quite significant cytopenias and toxicities in the patients.
Excellent. So I know Professor Facon is very keen because when I discussed with him at the time of the invitation, he was very keen on speaking about the IMIDs and some of these
Yeah.
adjustments in the elderly patient. When it comes to selinexor in your practice, what, beside, for instance, what you mentioned about reducing the dose, what are the supportive care measures? Because this is also part of the best practices, I would say,
Yeah.
because we are all very excited about whatever novel drug, but actually, what's even more important for a given patient is the supportive care. And I
Yeah.
can see finally Professor Facon
Great.
joining. He has been freed from the TGV. He was on his way from Paris to Lille. Hello, Thierry. Hello, Thierry. I,
Can you?
I said I'll file a complaint against the train company because they.
You can, you can.
Okay,
Definitely.
we already started with Elias. So, Elias, what are the supportive care measures you apply when it comes to selinexor? And then I'll jump into Thierry immediately.
No, it's I absolutely agree. It's important about the antiemetics. So when you start with the selinexor, it's important that you keep the dexamethasone dose if that's possible, at least for the initial few administrations, and that you of course use the antiemetics, which are usually combined like granisetrone or palonosetrone and one other drug like aprepitant, so that you really have a combination of the two drugs. And I would start this from the upfront. So my experience in the STORM trial was where this was not implemented, that nausea and vomiting was a very frequent problem. But since we implemented this with the approval from Selinexor and we use this triple antiemetic therapy, we have only very little problems with the drug.
Excellent news. This is really good news. So now I'm jumping to you, Thierry, and we started in the introduction about the importance sometimes in real life to go a little bit away from whatever written in a given label. And I think you have accumulated over the last 30 years because you dedicated your career to the management of myeloma in the elderly and frail patient. And maybe we can take the example of IMiDs also. We just spoke about selinexor. And how is this important? Because in theory, you should give 25 milligram of lenalidomide 21 days every 28 days. And at the end of the day, we have many patients ending with 10 milligram or 15 milligrams. So can you share your experience with us?
Uh, okay, so that's a very valid point, and of course, okay, if you want to start with IMiDs, I would say the lenalidomide can be, but we know when you design even a study with 25, you know that at least 30% of patients will get started with 10 because of renal function, and then some patients will dose reduce from 25 to 15 or from 25 to 10, and it's likely that you will also see, and this is not, as you mentioned before, this is not really in the, this is more real world practice. You have patients on 5, so you can generate patients on 5 or milligrams with some kind of good tolerance. But that being said, I do believe that IMiDs are not so. Okay, you could say LEN is 25 or 10. You could say POM is 4 or 2, something like that. But even in the labels, if you go back to the bortezomib story, for example, in the, bortezomib has almost 25 years. And when we got started with bortezomib, we did not know anything on proteasome inhibition. And then some people said, bortezomib is 1.3 IV twice weekly. That's it. It cannot be different. And as clinicians at that time, we started to see patients with neurotoxicity, and many of us ask about the 1.3 and not 1.0. Do we absolutely need the twice weekly? Why not weekly? And then we did studies having weekly bortezomib, and then we got the sub-Q. And basically we switched, or in few years we switched from 1.3 IV twice weekly to bortezomib once weekly sub-Q, and the tolerance was much better, and patients were able to stay on therapy for much longer period of time. And at the end of the day, the efficacy was better. So you have this bortezomib story, but you could say that in a way, so the Selinexor story is could be, I would not say it's a similar story, but it has something to do with that. The belantamab story is also in this line in a way, and I guess that the bispecific story will be probably the more or less the same.
I'll come back to bispecific,
Yeah.
but because you mentioned the issue of bortezomib and the IMiD, my question to you, Elias, this adjustment and whatever applying best practices and clinical judgment for a given patient is even more important when it comes to combinations. And we know, for instance, selinexor is combined with bortezomib, with pomalidomide. We combine bortezomib plus pomalidomide, PVD. I believe it's even crucial because it's, in terms of toxicity, it's not always like 1 + 1 = 2. It could be 1 + 1 = 3, 4, or 5. And so can you comment on this and maybe provide examples?
I think one example that comes to my mind is dexamethasone, and there is a very, very well conducted study from the Italian study group. And what they did is that they did a study where they put in intermediate frail patients, elderly patients, and they treated them with lenalidomide dexamethasone. And in the one group, they continued the dexamethasone, whereas in the other group, after some time, they stopped and just continued with lenalidomide monotherapy. And what you can see in the study is, if I recall it correctly, that the event-free survival in the group that stopped dexamethasone was longer as compared to the group that continued the dexamethasone. And at that time, Sonja Zwiegmann from the Netherlands wrote an excellent comment on that. And the title of that comment was Addition by Subtraction. And this is something that really holds true, that dexamethasone is a drug. There are some patients where you may need it in the beginning, of course, to avoid infusion-related reactions or to get a quicker response. But on the long run, dexamethasone is very unlikely to be a game changer together with the novel agents that we use. So this is one example where I think a landmark clinical trial has provided evidence that it's not important to combine just one drug after the other, but it's important to look at what is the adverse profile of the drug.
So I think that the corollary for this theory, and I think you've been always an advocate for this, that in general, especially in elderly myeloma, but this is true for all patients, it's a marathon, not a sprint. And you've been an advocate that we would rather go in a gentle manner and keep the patient on treatment. And this is exactly what we've seen in the summary of the paper I have presented about selinexor, where by just reducing the dose, they allowed patients to stay longer on treatment, and the efficacy proved to be better. And this is exactly, I think, what you usually advocate for.
Yeah, and back to the Elias said, yeah, I like the addition by subtraction. But you know that at the beginning dexamethasone, but you know that the VAD was published in 1984, and the VAD was 40 milligrams days 1 to 4, 9 to 12, 17 to 20. So 12 days every month with dexamethasone 40. Then we went to, okay, the Vincent Rajkumar said that we should use low-dose dex, and low-dose dex was 40 milligrams weekly. And then we said, okay, the elderly, should receive 20. And so you know, the beginning was 12 days with 40 milligrams. Then at the end of the day, we had 20 milligrams, 4 days in a month. And then we also decided to discontinue after some cycles. And as you know, the IFM has a study in which the frail patient will only receive dexamethasone for 2 cycles and then stop. And the need for dexamethasone is now less evident because we have several very effective new drugs. But the dexamethasone story is a good story in this sense as well.
And there are, just to echo the addition by subtracting, there are other editorials under, you know, the title, "The more is not the better," because historically, Bart Barloghi pioneered the concept, the more is the better.
Yeah.
But now it looks like that the more is not the
But
better.
you know, you should have you got started with lenalidomide, but the thalidomide story is more or less the same. He got started with 800 milligrams, and then we went from 800 to 100, something like that. And okay, then thalidomide disappeared in a way, but not everywhere. But okay, the thalidomide story is the same. Yeah.
And actually, I'm glad you're mentioning this, Thierry, because obviously we do have an international audience, and we do value all our colleagues practicing in low and middle income countries. And thalidomide continues to be a very useful and effective drug. And the IFM has run, and you led with Professor Yakubaga, the 400 randomized trial, 400 versus 100.
Yes.
And actually 100 proved to be more effective than
Yes.
400 and less toxic.
And going, if you want to say something about the real life, you have very likely patients on 50 milligrams thalidomide in some countries.
And that brings me, because we're talking about the IMID, Elias, we have also, beside the first phase of treatment, let's call it the induction, you know, when the disease is quite active. So we just heard we need to be careful how to start to avoid early discontinuation, because at the end, we will all lose, including the patient. Dexamethasone is a good example. Lenalidomide starting dosage is a good example. Selinexor starting dosage is a good example. But there is the continuous therapy, the so-called maintenance. And again, for instance, a good example is lenalidomide over the long term. And while initially, and I think the label of lenalidomide is continuous therapy, we like to give holidays for patient of treatment, like treatment-free interval. Can you comment on this?
So I think this is a very, very important angle where the community really needs to, or the academic study groups really need to conduct more studies to get more insights on how and which patient population can have a benefit from, let's say, a treatment break or perhaps even a discontinuation. So I think this is a very general and very interesting and important topic. I think the longer the patients are on lenalidomide single agent maintenance and have a stable, deep response, the more they come to me in my clinical practice and say, okay, when can I stop this treatment? Or I have continued issues with, let's say, with the gut or with digestion or with diarrhea, or I have cramps in my muscles. So it seems that the side effects that are not, let's say, severe for us from a medical perspective, but they are severe for the patients from the patient perspective. And in that regard, I always try to find solutions with my patients. And one of the solutions, besides the dose reduction, is that I say, okay, we do very frequent checkups, let's say every 2 to 3 months, to see if we do a dose reduction, is the disease still stable? So that gives the patient a lot of psychological safety. And I think this is important for the patients. That's what I learned from my patients. And one other thing that I commonly do now, and we discussed this last year at EBMT, that's why I'm picking it up again, is that in the maintenance setting post-transplant, after some time, I say to the patients, it's okay if you take the drug for 3 weeks and then you have 1 week off so that the blood count can recover. And this is something in my experience that helps a lot for the patients.
No, thank you, Elias, for highlighting this. And I would personally add that, and I hope Thierry will agree with me, that we also pay attention mainly to grade 3 and 4 toxicities. However, when you have diarrhea with lenalidomide, a grade 2, and actually we rarely spend time, getting the right definition, what is grade 2 or grade 3? Grade 2 is an increase of 4 to 6 stools per day over baseline, which for a patient, for instance, if you have to travel for 3 or 4 hours going to your holiday home, would be a nightmare because you have to find a restroom every hour somewhere, to stop. And it's a grade 2, and we feel it's not life-threatening. But in terms of quality of life, this is a disaster, I think. Thierry, what do you think?
No, I fully agree with you, and okay. For example, it's the same story with bortezomib and neurological toxicity. At the beginning we said okay, the grade 3 is infrequent, but we had patients with grade 2 and pain, and so the patient said okay, but I have pain. So you cannot say you cannot, and it's a very general comment. So I think it's not totally optimal to look only at grade 3 and more, because in doing that, basically you don't take care of quality of life. You don't have the full picture of toxicity. But that's the global, that's this debate on continuous therapy versus fixed duration therapy has emerged many years ago at the time of lenalidomide was approved as a continuous drug, and so I think the debate got started at that time, which is basically almost 20 years ago, and the debate is still a valid debate. And but on the other hand, I will just take 2 examples very briefly. One is you have patients with no diarrhea, no cramps, on lenalidomide low dose, and at this point they may have some benefit of continuous therapy, and Elias said the psychological safety. So they are confident. Just having even 5 milligrams of lenalidomide makes them confident, and they have no adverse events. And some patients do accept to stay on therapy, and they feel well with some kind of prolonged or continuous therapy. And then the other example is that you cannot say myeloma, as you know, myeloma is not one disease. So the high-risk patients, for example, it seems that they benefit more from prolonged therapy or even continuous therapy as compared to fixed duration therapy. So this debate is not a very easy one, and it's still an important and valid debate. And so you can support continuous, you can support fixed duration. The week after, you can do the opposite if you want, because you will find strong arguments on both sides, basically.
No, thank you, Thierry, for bringing this, because that allows me to have the transition with this issue of fixed versus continuous. And one great example we've seen in myeloma, and this is what makes the beauty of this treatment, is about CAR T cell, because this is a fixed duration treatment, single shot, and then the patient, at least as of today, I don't know tomorrow, because there are protocols combining CAR T cells with other drugs, patients are enjoying treatment-free interval. And actually, if we compare to bispecific antibodies, if you look to the median PFS, and we all know this, actually the median PFS of ide-cel or teclistamab are roughly the same, but still, from a patient perspective, having a sort of a single shot treatment and then wait and watch is always preferred option. Elias, what is today your thought personally, but also maybe the German colleagues, or the way you perceive this in Germany, this issue of fixed versus continuous treatment?
With the novel agents or with the bispecifics and CAR T cells, I think first of all, there's always something I tell to my patients, and I want to make a little controversy out of this. So I tell these patients, of course, the CAR T cells you receive are a single shot. You get a single infusion. I agree with you in that sense that you can call this a fixed duration. But be careful, because the cells inside your body, they continue to live and they continue to proliferate and they continue to be there. And that's what I tell my patients, especially if they come with very high expectations and say, okay, doctor, I have read in the newspaper that I get one single shot of this treatment. You discharge me after 5 days and I'll never come back because I'm cured. Then I say, okay, be careful, because you get a single shot, that's right. But we need, first of all, we need to get your T cells. We need to get them ready. Then you get flu-cy conditioning. Then you receive the CAR T cells, and then they live within your body. And a significant proportion of patients has significant cytopenias, side effects, severe infections. And once the CAR T cells are inside the patient's body, we cannot eliminate them after anymore, right? So you added the CAR T cells and you have a patient with severe cytopenia, and we have seen reports that coming up within last years that you even try to support these patients with autografts and with growth factors and things like that. And we really have patients that die from this single shot treatment. And if you compare this to the teclistamab or to any bispecific that you give, in that case, if a patient experiences severe cytopenia, I can say, no problem, I stop here and we wait for the cytopenia to recover. Or I have elderly patients on teclistamab, they would never have made it to a CAR T cell because they are too frail. And I don't give them teclistamab every 2 weeks. Yeah, as you can figure out now already what I said. I give them teclistamab every 4 weeks and only half the dose, and it still works. Yeah, so again, with every drug class that we have, and I would like to add here to what Professor Facon says, it was also the story with carfilzomib, for example. That's another story. We never know the ideal dose. And one reason for that, just give me 10 more seconds, because I want to highlight this here. The reason for that is because academia and pharma, everyone, we do a mistake when we try to find the right dose in the patients. We do this simple 3+3 design, where we just give a drug until we reach a dose-limiting toxicity. Of course, that's a way to find out how much drug you can give to a patient, but it's not a way to find out if this drug is efficacious in this patient or not. And that's a very, very general problem. And I have no drug on my mind where I would say, okay, the dose I use is just optimal. It's not with pomalidomide, not with thalidomide, not with belantamab, not with carfilzomib, not with bortezomib. So we've already named them all. And it's the same with the bispecifics. I can tell you from our German trial, where we use it in the first line setting, and also in the other studies, it's very difficult to find the optimal dose. Yeah, so
I think but you're bringing a very valid point, and this is about the historical way of developing cancer drugs, and that was about, with conventional chemo, trying to find the MTD, the maximum tolerated dose.
Right.
And now we have agents with a totally different mechanism of action.
Exactly.
And we have to move to the minimum effective dose concept. And I believe some regulatory agencies are really working on this. So we have to really acknowledge the efforts. But it's not easy to change the culture of a whole field instantly. But this is exactly, I think, what we should aim for. So Thierry, You mentioned when you just arrived to the session the issue of bispecific. So we heard from Elias the dosage, which may not be the optimal, but there is also the schedule, the duration of a cycle. And the original development, whether with teclistamab, elranatamab, talquetamab, all of them leading to great results, has been just hammer the patient every week. Although I must acknowledge, for the sake of scientific accuracy, that with elranatamab, they allowed to move into twice monthly after 6 cycles in the magnetism-3 trial. So what is your view today on maybe how we're going to use the bispecific in a couple of years, or 3 or 4 years? I'm sure it's going to be a story like bortezomib. We're going to invent our SOP for using them.
I think so. That will be in a way a similar story. In fact, we don't know. We don't know the dose. We don't know the schedule. And as you said, we got started with weekly, with the, and I guess that the first thing, I do not believe that bispecific antibodies are continuous therapy. I think you will not, you could claim that lenalidomide could be continuous or not, but I cannot imagine that bispecific antibodies will be continuous therapy, because you will create anyway infections or something like that. So basically, in doing that, you take the risk of seeing severe infections in MRD negative patients, for example, let's say. So that, I think that you will have to stop at a certain time point. This time point is not defined. You could say this time point will be defined by MRD or whatever, or the frail patient will get less, the fit patient will get more anyway. But I think we will discontinue at a certain time point. Then I guess that the schedule will even every 2 weeks is too much, because at the age of 80 years you will not come back to the hospital every 2 weeks, for even if it is for a sub-Q injection of a bispecific. So the every 4 weeks and maybe every 8 weeks. So and you don't know at the end. These drugs are so effective that at the end of the day, that could be you may get a bispecific 3 or 4 times in a year, and in combination with something different. So nobody knows, but I think in 10 years from now, the dosing and the schedules of bispecific antibodies will be very different from what we have today.
So what I understand from both of you, actually, and I think, please correct me if it's a wrong statement, is that we have to acknowledge the work of our pharma colleagues doing their job, trying to tick all the boxes to get the approval, because that's important for all of us, of a given drug. And then it's our mission as academia physicians to see how we're going to use them in the real life to fulfill the needs of Mr. Everybody, of any patient, because obviously the patient of a given clinical trial are not necessarily the ones that you're going to see every day. So this is very clear. And for the last 5 or 6 minutes of this journal club, I would like to expand on another parameter, which is not only about, which I believe is about the part of personalized treatment. It's not only about the dosage, the toxicity, the schedule, but also maybe the convenience and patient preference. And for instance, if we look today, depending on which country you are, so I'm not going to designate a specific country, but you have in the same, I would say, niche, Selinexor oral drug, belantamab systemic drug. You have the bispecific anti-BCMA. You have bispecific anti-GPRC5D continuous. And by the way, I forgot to mention that one of the other bispecific, cevostamab anti-FcRH5, is developed as a fixed duration treatment. So just for the record. So how do, and we have CAR T cells, of course. And all of these options are actually within almost the same niche of indication. And so how do you consider in your practice patient preference, traveling to the clinic? I like the hospitalization. I don't like to be hospitalized. How do you handle this? Just
okay. You did not you did not mention CD38.
absolutely,
But
absolutely.
if you want to be very provocative with CD38 antibodies, let's say the old daratumumab, the design, the schedule is interesting. The schedule was well designed, to be honest, giving more at the beginning. Then after 6 months, you get daratumumab every four weeks or so. That's a monthly. But in the Cassiopeia study, for example, we delivered daratumumab every 8 weeks, and it was not bad. So if you go back to the frail patients, so patients who have received, let's say 30, 40, 50 cycles of DRD, why not moving forward with daratumumab every 8 weeks? It's not part of the label anyway, but it could be useful for some patients. So I don't know. You may find patients who, okay, I think the vast majority of patients prefer to stay at home, to be honest. But if you say to even an elderly patient, you will have to come back to the hospital every 2 months, and at that time you will get a sub-Q injection of this and a sub-Q injection of this, and okay, that's at the end of the day, that's 6 times in a year, and you may or may not have to take a pill or to take some lenalidomide, for example, but that's not that difficult to design gentle regimens for elderly and frail patients. It's just to do it, But I think you can. The label is the label, and the label is important because it has been done like this in clinical studies. But then after some years, and also because we have to combine drugs together, and the academic teams should provide answers to that. They should do studies investigating new regimens and regimens for the patients in the real life, I would say.
Elias, what is your take on this?
No, I think I'm happy that Thierry was answering first. So it's a difficult question you asked for the end now, for the final. So I think patient preference is something where it all comes down to clinical experience as well. So I can only add that I think for some younger patients that are afraid of coming to the clinic, I sometimes push them and say, okay, now it's important because you're only 50 or 60 years old and you're otherwise fit. So please come, and we can see during the course of the treatment how we can reduce the burden of coming to the hospital. Whereas in the elderly patients, I often have the discussion with my patients that they have different goals in life. And that's something that I always try to emphasize at the beginning of the treatment, that I meet the patients 2 or 3 times and that we talk a little bit about that together with the family, or maybe some people that join them, like friends or partners, and try to figure out, okay, what's important for them. And I fully agree with Professor Facon that I say sub-Q treatment is always something that I would prefer, and an oral treatment as well. But in some very frail patients, I prefer a little bit the sub-Q treatment, because then I have more of a control what they receive. And I just want to end with a nice example of a patient that is just become a little slim crab positive with a very high IgG value and light chains around 2000, but everything else was stable. No osteolysis, no bone lesions, 30% bone marrow plasma cell infiltration. And this patient is 93 years old. And we just started 4 weeks ago, and we said, okay, the first thing we do now is we just do daratumumab mono subcutaneously. And this patient is doing very, very well, and it's an individual decision. And we even started only with dexamethasone 16 milligrams for the first 3 administrations, and now we put it down to 4 milligrams because he did not react to the sub-Q. And this is just a perfect example. I just met this patient last week and he was very happy and he said, it's not a problem. I come here every week and I know after that it will be only every 2 weeks and then every 4 weeks, and he's doing well. So, and I think we still have the option because we treat this patient early. We did not wait for renal failure or for hypercalcemia or for a fracture or something like that. Now we have the opportunity to see how the daratumumab works. And if it will not work, we can think what we want to do, like adding a little bit lenalidomide or adding a little bortezomib. So it's always good to start early if that's possible.
This is really fantastic, and I would like to thank you both for sharing your experience, like this nice example, your knowledge, your wisdom, and what is clearly reassuring for me, and I'm sure for many colleagues who are following us, is that it doesn't look like that artificial intelligence will replace or take our job very soon, because definitely, and this is exactly the spirit of this journal club, which is an unusual, I would say, special one. But I was very pleased when I saw the title with the steering committee of this article, which led us to this discussion, the impact of breast practices program when using Selinexor. And I thought, actually, this could apply to everything we do in myeloma and beyond. So we have lots of good news. We can adjust the treatments that will allow to improve the outcome of the patients, their adherence, and we're going to keep our jobs because actually you still need the brain of a physician, and this is absolutely about the art of hematology and oncology. So thank you so much. Thanks to our audience. This is the International Academy for Clinical Hematology around the globe and across the hematology field. Take care and see you soon.
Bye-bye. Thank you, Mohammed.
Bye-bye.
Thank
Thank
you,
you.
Elias.